Other sodium eliminators, such as chlorothiazide, that is diaryl, may be employed. The dose of diaryl is 500 milligrams daily for a week, and then 250 milligrams daily thereafter. In general, it is advisable for scientific reasons to employ those drugs which have the greatest potency on a milligram basis. Esidrex is 10 times more potent than diaryl and therefore is preferred. Esidrex has only moderate hypotensive properties when employed alone, but when employed with reserpine, a satisfactory control of blood pressure may be obtained in a significant percentage of patients. Studies in animals have borne out the clinical impression of greater potency of hydrochlorothiazide as compared with chlorothiazide. With equal doses orally, it has been shown that the diuretic effect of hydrochlorothiazide is considerably longer than with chlorothiazide. In the dog, sodium was excreted in equal amounts with both of these agents. However, there was less excretion of potassium with Esidrex than with diaryl. If hypertension still exists after therapy with reserpine and hydrochlorothiazide, hydralazine or apresilene is added next. Apresilene is a useful hypotensive agent which may be administered in addition to other hypotensive agents such as reserpine and Esidrex. The dosage schedule starts with 5 milligrams, that is, 1/2 of a 10 milligram tablet daily for a few days, increasing the dose by 5 milligrams every other day until 50 milligrams or even 100 milligrams a day is employed. This ascending dosage schedule is used because of the tendency for headache and tachycardia, which seems to be less of a problem when the drug is administered in this manner. Also, it is highly important to administer apresilene after priming doses of reserpine to minimize the apresilene headache. A rare complication is a rheumatoid arthritis-like picture, which at times resembles disseminated lupus erythematosus with LE cells. This is more common when large doses are given, for example, from 400 to 600 milligrams daily. With 50 milligrams daily as employed here, arthralgia is an exceedingly rare complication of apresilene therapy, but when it occurs, the drug should be stopped and ACTH and prednisone administered. Apresilene is a central inhibitor of vasomotor reflexes. It neutralizes a vasopressor substance, and it is a renal vasodilator. Also, it is a mild inhibitor of epinephrine and norepinephrine. It is probable that apresilene has not received the attention which it deserves because many physicians have initiated therapy without previous priming with reserpine or have started therapy with large initial doses. As a result, side effects were common and often the drug was discontinued. Also, at times, physicians have attempted to use apresilene as the sole agent to lower blood pressure, and the results have been disappointing. However, when the agent is used with reserpine and Esidrex, a gratifying additional fall in pressure usually occurs. It should be emphasized that apresilene is unique in that it is the only practical agent to increase renal blood flow and to reduce cerebral vascular resistance. Apresilene induces a gradual and sustained reduction in pressure, usually without the development of postural hypotension. Apresilene is an effective agent for counteracting hypertension of neurohumoral origin. It should be recalled that one mechanism for the production of hypertension is renal ischemia. As a result of ischemia, the kidney releases a vasopressor substance which produces a generalized constriction of small arterioles with an increase in blood pressure. If the blood pressure remains persistently elevated, there results nephrosclerosis, which further decreases the renal blood flow, which in turn produces a further release of vasopressor substance. Thus, a vicious cycle is established which results in an ever-increasing blood pressure. By decreasing renal ischemia through dilatation of renal vessels, this cycle is interrupted. A persistent blood pressure elevation may have other effects, such as an effect on blood fats. The reported findings of Perry and Schroeder that apresyline administered orally to 66 hypertensive patients resulted in an average cholesterol fall of 48 milligrams percent in the first 6 months are of interest. In similar investigations, Corcoran in one study and Ganglionic in another observed a fall in blood cholesterol and lipoproteins with antihypertensive therapy using some of these agents. These studies deserve further consideration. The actions of apresyline may be shown experimentally. Cross-circulation experiments in the dog have shown that stimulation of the afferent vagus in one dog produces a humoral substance which raises the blood pressure in the second animal. Apresyline blocks this hypertensive effect. Apresyline also blocks some pressor reactions. For example, it blocks the bradycardia, which ordinarily occurs following the injection of norepinephrine, which indicates a central site of action. The pressor response to breath holding is inhibited, and the cold pressor reaction is diminished. The Valsalva overshoot blood pressure reaction is prevented, and the tilt-back overshoot blood pressure reaction is depressed. Some of the induced digital vasoconstrictor reflexes are inhibited also. In addition, epinephrine given after apresyline shows a diminished hypertensive response. Guanethidine, or ismalin, is a new agent which has a definite place in the treatment of essential hypertension. If the combination of reserpine, esidrex, and apresyline does not control the hypertension adequately, then ismalin should be added. This agent is administered in doses of 12.5 to 25 milligrams daily, although larger doses may be tolerated by a few patients. The agent blocks the release of epinephrine or epinephrine-like substances from the sympathetic nerve endings. Ismalin is unique in that it is the only practical therapeutic agent which blocks the sympathetic nervous system at this site. The agent has no significant hypotensive effect when epinephrine is injected into a patient or animal. Thus, ismalin is unlike the adrenergic blocking agents, Regitine, Ilidar, and dibenzoline, as these agents prevent epinephrine from acting on the effector organ, that is, on the blood vessels. Ismalin is thought to act like the cork in a bottle of liquid, which would prevent the fluid from leaving the bottle. Some of the side effects of the agent are general weakness, postural hypotension, and with overdose, Horner's syndrome. This agent is definitely to be preferred to the ganglionic blocking agents because the dose of the medication is small and can be administered once a day, and because only the sympathetic nerves are blocked, the parasympathetic nervous system being unaltered. Thus, one does not have the complications of constipation, dry mouth, and urinary retention. If Serbicil, Esidrex, apresyline, and ismalin in combination do not handle the hypertensive problem, then one is forced to employ the ganglionic blocking agents. There are a variety of these agents available today, and the important ones are listed in Table 2. The ganglionic blockers all have the disadvantage of parasympathetic blockade with constipation, blurred vision, and dried mouth. In addition, there is blocking of the sympathetic nervous system, which is associated often with postural hypotension. In general, the ganglionic blocking agents are the least satisfactory group of drugs to employ for the treatment of essential hypertension, and therefore are administered as a last resort. When they are used, they should be employed with the other hypotensive agents which have been described previously. When a hypotensive agent is needed, Echolid may be used and is administered twice daily. As with all ganglionic blocking agents, individualization of dosage is essential for optimal results. No fixed dosage schedule is appropriate for all patients. but rather it may be necessary to increase the dose gradually over a period of several days to several weeks to lower blood pressure toward normal. The following dosage plan for ambulatory patients is acceptable. On the first day, 10 milligrams is administered in the evening. On the second day, 10 milligrams is given morning and evening. On the third day, 10 milligrams is repeated in the morning, but 20 milligrams is given in the evening. On the fourth day, 20 milligrams is given in the morning and 20 milligrams in the evening. On the fifth day, 20 milligrams is administered in the morning and 30 milligrams in the evening. This dosage schedule may be continued until a satisfactory hypotensive response occurs or until mild postural hypotension develops. The average maintenance dose is approximately 50 milligrams twice daily. It should be kept in mind that patients receiving other hypotensive agents concomitantly, such as Serbensil, usually require small doses of Echolid. Echolid is advantageous because of its relatively long action, which allows the drug to be given twice daily. When a prolonged effect is desired and when the drug is given twice daily, the agent should be administered after meals. For a more predictable effect, the drug may be given on an empty stomach, that is, before meals, in which case 3 tablets daily are employed. Side effects with the ganglionic blocking agents are frequent. Visual difficulties may occur. However, they tend to subside with continued use of the drug. Dark glasses of 1 or 2 diopter corrective lenses are helpful. Pilocarpine orally in doses of 5 milligrams or the local application of this agent is useful. Constipation is frequent with Echolid. However, it is usually controllable with simple laxatives or with prostigmine 15 to 30 milligrams orally. Postural hypotension is not uncommon with Echolid, and the danger of this complication is cerebral hypoxia or injury from falling. The patient should be warned about the possibility of postural hypotension and should be instructed to avoid prolonged standing, especially in hot weather, and he should sit immediately if he becomes dizzy or feels faint. A dry mouth is not uncommon, but this diminishes as the drug is continued. Chewing gum and 5 milligrams of pilocarpine are helpful. Urinary retention occurs occasionally, but this may be transient. The patient should be instructed to void before each dose, and neostigmine may be administered if necessary. It is apparent from this discussion that the treatment of hypertension involves the use of more than one drug in many cases. This is because of the numerous factors which are responsible for the maintenance of the high peripheral resistance which is characteristic of essential hypertension. Figure 1 shows some of the neurogenic, chemical, endocrine, and other factors which regulate vasomotor tone and control blood pressure. It is the balance of the vasoconstrictor and vasodilator forces which determines the peripheral vascular resistance. With further study, it is possible that a better understanding of the factors which increase the peripheral resistance will be achieved. In the meantime, we should continue our therapy of essential hypertension using those methods which are effective, even though their use is in some instances empirical.